all of you who are here for this instruction course on keratoconus, some of the newer approaches to managing keratoconus. Thank you, all of you, for being here early in the morning on a Saturday. We'll get started with the instruction course shortly. But before we have the instruction course begin, we have a preview talk, which is going to be about Liftegrast, and Dr. Namrata Sharma is going to be speaking to us about Liftegrast, and we'll also try and find out if it can be used in keratoconus in some way in the future.
So thank you, Praveen. So I'm going to be talking about Liftegrast ophthalmic solution. Can I have the presentation? Liftegrast ophthalmic solution 5%, a review in dry eye disease. So dry eye disease, as we know, is defined by Dews as a multifactorial disease of tears and ocular surface, which results in the symptoms of discomfort, visual disturbance, and tear film instability. And chronic inflammation is an important part in its pathogenesis. Now, if you look at the ocular surface immune response, a healthy system can respond to any injury by mounting a response to eliminate the pathogens. But if there's a dry eye disease, then it is a spiral of immune response with loss of return to hemostasis. So Liftegrast is the drug which is being used or has been used to treat dry eye in other countries, and very soon it is going to be available in India. It has got high aqueous solubility, well tolerated, short half-life with high clearance rate and low systemic exposure, isotonic with human tears, unique mechanism of action, rapid absorption into the ocular surface, and rapid systemic elimination. Uh, it protects the corneal surface and is well tolerated, and it does alleviate all the symptoms of dry eye. Now, it has a mechanism of action, and that is basically there is intercellular adhesion molecule which is present in the epithelial, endothelial, and the immune function cells in the inflammation. An increased expression of ICAM1 and T cell infiltration is seen in conjunctiva and lacrimal gland of the patients with dry eye disease. And ICAM1 is a cognate ligand of this lymphocyte function associated gene, or LFA1, which is an integrin expressed on the T cells. So once this formation of the synapse between the LFA and ICAM occurs, this causes T cell proliferation, cytokine release, and recruitment of more T cells. And LFA1 ICAM1 interaction has a major role to play in ocular surface inflammation and ocular immune response. So Liftegrast is basically a lymphocyte function antigen 1 antagonist, and it suppresses the inflammation by mimicking ICAM1, and it blocks the interaction between LFA1 and ICAM1. And so it disrupts the various key steps in the T cell mediated inflammation. So once that happens, the T cell activation is inhibited, cytokines are inhibited, it inhibits the formation of immunological synapse, and there's decrease in the ocular inflammatory cycle. And like I said, it is already being used in other countries, but in India it will be available shortly. Now, this is just to show the mechanism which I have already talked about. And these are the summary of the Liftegrast trials. Phase 1, Phase 2, Phase 3 studies have already been done. And they are by the name of the OPUS trials. And if you look at the studies which are published in literature, then Liftegrast in its multicentric trial also has shown that it shows improvement in the signs and symptoms of the dry eye. It reduces the corneal fluorescein and conjunctival lissamine staining, and also has been shown in a large number of cases to decrease the corneal epitheliopathy. And these were all placebo-controlled studies and double-mask multicentric trials, which have shown that even in terms of ocular surface disease index, and the patient symptoms also get better with it. Further, it is safe and it is well tolerated. So these are the OPUS trials which are done, and topical administration of Liftegrast is done 5% twice a day. And in these randomized phase 3 studies, there were 3 periods which were looked at: screening, treatment, that is days 0 to 84, and follow-up day 85 or 86. And the eligible patients were more than 18 years who had minimal signs and symptoms of dry eye disease. Now, this is the study, multicentric study, which was done in India, and this was a randomized double-blind parallel group activated controlled multicentric phase 3 study which compared the efficacy, safety, and tolerability of liftigrast 5% versus CMC in patients with dry eye disease. The primary efficacy point was the eye dryness score, the ocular discomfort score, the OSDI change, the breakup time in the tear film. And the secondary endpoints were the Schirmer tear test, the corneal fluorescein staining, and the subject rated global improvement scale. So, a total of 370 patients were recruited, and the study was conducted across 10 centers in India. And the group A, after unblinding, was actually the liftigrast 5% eye drops, and group B was the CMC 0.5% eye drops. So, in terms of age, height, weight, and gender, both the groups were well matched with no difference between the two. And we compared the eye dryness score, then the trend of decrease in the eye dryness scores was seen in both the groups. There was gradual decrease from the baseline to study end, and this was significantly more with liftigrast than with the placebo. Likewise, there was a gradual decrease in the ocular discomfort score, which was again significant with liftigrast as compared to CMC. And so was for their tear film breakup time, where again it was significantly better. In terms of Schirmer tear test, the corneal fluorescein staining score, conjunctival redness score, all of them statistically were significantly better with liftigrast than with CMC. And this was the percentage of change in the study parameters in both the groups. The percentage of changes were higher with the liftigrast as compared to the CMC again. If you look at the adverse events, they were present with both the groups again, and the proportion of subjects in liftigrast group had as adverse events was 3%, itching, irritation, and burning, and the one in CMC was 5%, where foreign body sensation and headache were also present additionally. However, all of these were mild to moderate and they resolved without any sequelae. So, this is essentially the summary of the study, which I have already enumerated the results about. And even in the OPUS trials and other studies, it was shown that there are no serious ocular events. However, dysgeusia or altered taste sensation has been reported in 13% of the patients with the OPUS trials. So this was about the liftigrast, and I'm sure the company is going to market it very soon, and it is going to be available. So thank you very much for your kind attention.
Thank you, Namrata. If there are any questions for Namrata as we actually shift to the actual instruction course, we'll be happy to take them now. Yeah, we'll text you if there are any questions. Thank you. So we'll actually start with the instruction course on keratoconus. This is titled Keratoconus Newer Advances, and would request my co-instructors to please come onto stage. Ritika, Dr. Rohit Shetty, Rashmi, I think, is on her way here, and she'll be here shortly. So just to go through the course, this course is designed as a more advanced course for keratoconus, where we'd like to explore the current avenues for diagnosis as well as some of the emerging treatment modalities for keratoconus. So not just the typical topography and diagnosis kind of course. So we'll actually have Dr. Rohit Shetty start off speaking about the recent advances in the diagnosis or corneal imaging for keratoconus, followed by Dr. Ritika Sachdev, who's going to be speaking about corneal biomechanics and also epithelial mapping in keratoconus. Then we're going to be exploring the current concepts of cross-linking and how they're changing. And following that, we'll speak a little bit about the surgical interventions for keratoconus, including stromal keratophakia, so sort of non-linear kind of approach to keratoconus. So first up, would like to invite Professor Rohit Shetty. Rohit, as all of you know, has done some seminal work in the area of keratoconus over the last decade and has also published a lot in the early diagnosis as well as detection of keratoconus. So Rohit, the stage is yours. Thank you very much.
Thank you, Praveen, and it's wonderful to be part of this IC again. The talk is on newer diagnostic modalities in keratoconus. These are my financial interests. I'm sure it's not going to affect what I'm going to speak in this session today. All the diagnosis of keratoconus relied heavily on indices. Many indices have been compared head-on with the others. Unfortunately, we can never compare one company's indices with the other because the way it's designed is completely different. The question always comes is, are they adequate for diagnosis of early keratoconus? So when you look at the diagnosis, anatomically, you look from the epithelium, the stroma, the biomechanics, imaging, and also things which are beyond just imaging perspective, the biomarkers, some of which may have relation to what Dr. Namrata just mentioned today. The epithelium is known to be one of the earliest changes of in keratoconus, and the work done by Artemis by Dan Reinstein in a very early stage spoke a lot about how the epithelium changes can have a huge impact in understanding the keratoconus even before the stroma has started changing. Over time, we have machines like Cassia 2, the MS39, uh, RTView. Many companies of ASOCTs have now or have built in their epithelial maps or in the process of building one. But what's interesting for me from an epithelial point of view is just not the early detection. It's about impact of epithelium on your on the optics of your eye, including your cylindrical component or also the higher order aberrations. MS39 is a smart tool. It gives you the cylindrical component arising from your epithelium. It also gives you the coma and other aberrations arising from your epithelium. So if you are trying to treat anything on your cornea, you have to factor this in because many times epithelium itself could be a major factor for coma, and that's what you're discarding or taking it off. And you may be treating what you have it on the cornea, on the epithelium, you may be actually treating on the cornea. So these factors were never considered in the previous laser based systems, and you can see the difference between these two with a significant amount of coma just from your epithelium. This is very important as far as keratoconus is concerned. It helps in suspicious cases. Early coma changes might help in detecting it's from the epithelium. And when we look at what really makes this epithelium changes, then you go next layer would be the corneal nerves. The corneal nerves have different functions. They maintain the hemostasis of your eye, epithelium, and other functions. You have a lot of these patients have multiple changes on your nerves. One, they may have less density of your nerves. They may be filled with dendritic cells, which are signs of ongoing small inflammations. Many of them have very insignificant microneuromas out there, terminal bulbs on your corneal nerves. Without understanding all this, let's assume that you treat these patients with, say, cross-linking. Your outcomes of cross-linking completely differs. The reason being, all these factors here have a huge implication in wound healing, and each of these factors have an impact on how the corneal stroma heals to a particular insult. And these are filled with different types of molecules, some of which what Namrata ma'am had just discussed. And this is what you end up with: severe amount of scarring, severe amount of excessive flattening, severe amount of things which are beyond your control. So understanding the hidden mechanism in the corneal nerves and all these related structures are very important in looking at the outcomes of your cornea. The stroma imaging started getting a lot of interest again after MS39 came into the picture. It's just a software driven. It what it does, it just takes out virtually the epithelium and then gives you the elevation of your stroma. For example, without the epithelium, this is your how much you see elevation. This is a true elevation because many times the epithelium will mask the whole structures. And you can look at it from a surgical outcomes. You can look at what is happening especially in keratoconus. If you look at it from a progression, your real progression is from the stroma, and you can see that this keratoconus progression, how it's progressed. And sometimes you can have patients who are very stable. The epithelium might be changing. Epithelium is very dynamic. You treat the dryness, you treat the ocular surface, the epithelium might change, but the true stromal elevation does not change. And true stromal elevation could be a very important factor when you look at the corneal progression. For example, in this case, it's it's trying to flatten on the topographies, but you can see that the stroma seems to be perfectly the same. So flattening could be induced by an epithelial change itself, which your pentacam will probably not fit. And you can see that the 14, 13, these are the values which you see exactly in that zone. After the stroma comes the biomechanics. A lot of work has happened on biomechanical assessment on the corvis. Multiple parameters have come in. Uh, you have the DA ratio, integrated ratios, ART1, and CBI, TBI. But for me, SPA1 is one of the most important factors, especially to look at the corneal strength. Anything above 100 is considered normal strength, because this is not heavily dependent on your corneal thickness, intraocular pressures, and multiple other hydration parameters. All the other things here are heavily dependent on your IOPs. If IOP is high, everything is falsely low or falsely high. The other thing which is not dependent on the IOP stress strain index, but Ahmed El Sheikh, where closer to 1 means it's stronger. And again, this is independent of corneal thickness. But when you look at biomechanics, you have to look at things which are independent of corneal hydration, thickness, and IOP, because otherwise everything gets affected by these things. Uh, the Brouillon is a very interesting concept which looks at looking at the biomechanical modulus at different parts of the cornea. But I have never seen a more uh, uh, it's not moving here. It's not moving. Yeah, and this looks at different the biomechanic at the different places. We have this machine, but I have one of the very moody, whimsical machines I've ever used. 90% of the time, it doesn't work only. So we have no idea. I mean, this we got it for a joint grant. I really don't know what to do with it, because the company gives keeps asking us to do multiple things. When it works, it gives you these kind of changes, but in theory, it's a great tool. But in practice, I don't think it's going to ever come into clinical use with this kind of a backing. We started working on collagen imaging from 2015 because we wanted to study the real factors which change in the keratoconus, because these are important factors. The collagen one, your lysyl oxidase, which hold them, because different corneas have different types of collagen, and your topography is not a factor to look at what is going to happen, what kind of collagen you have. It uses the polarization right. Birefringence is your principle. We collaborated with a few centers, and we started building the first collagen imaging. And now it's standard of care in my clinic. Every single patient, I do it within, it just takes 1.5 minutes per eye. And the report comes instantaneously, which we have generated. And you can see that the darker checker pattern looks healthier. The lighter blues, the turquoise blues, means the collagen properties have changed, and absolutely no dark blue means your property of orientation of collagen is completely lost. So we are with immediate effect, we're able to image the collagen, and instead of just looking at just the parameters and all the indices, you are actually looking at the true collagen what you have. And advantage is that you can look at it from a progression aspect of it. You can look at the Bowman's layer. This is your Bowman's thickness, epithelium. Every layer of cornea in keratoconus can be seen, and this is a stable keratoconus, and it's very interesting. This is your Bowman's, which is on 2021, and in 6 months you can see that the Bowman's is thinned out. So you can even map the way the Bowman's is thinning out, and Bowman's is just around 4-5 microns, around 2-3 pixels of it, but still this is a 1 micron resolution. So and you can see that the collagen changes. This is your collagen before, and collagen changes. So degradation of collagen can be picked up much earlier, and you can use this actually to study the outcome of your procedures also. Uh, the biomarkers have a very important role because when you look at these kind of cells, the cells which are functional and cells which are stress, which don't function as it should be, they secrete a lot of cytokines, and many of these cytokines are the ones which drives the diseases, and these things needs to be looked at and evaluated. So we developed our own biomarker kit from the tears, and we look at all the cytokines. And Dr. Namrata mentioned about the ICAM1. Our kit also is able to look at ICAM1, so you can decide if it's high. In this case, the liftigrast, what she said, may not work because there is no ICAM1 in this patient. So based on what is higher or lower, you can actually choose, and this is what we are working on. It's a very long process of choosing the drug based on what molecule you have, and you can see that this is where probably the liftigrast might work in your patient. But without knowing, just treating it for everybody may not be the right way to go. And these are all the papers which we published on how we can use the drug to titrate it to what is necessary in terms of progression. So understanding the epithelium is important. The stromal imaging, I think, is going to be the future. A combination of topography and biomechanics is great, but we need to refine it more. What I'm really betting on is understanding the collagen itself. And the most important thing which controls everything is the ocular immunology. Thank you, Praveen and team, for this opportunity.
Thank you, Rohit, for amazing talk. As always, very comprehensive, not just looking back at what is available right now, but also looking into the future about what to expect. So, any questions for Rohit about the current as well as the future modalities of imaging for keratoconus? So, as we have our next speaker, Dr. Ritika Sachdev, set up, and Dr. Ritika is going to be speaking a little more in depth about epithelial imaging as well as biomechanics in the diagnosis of keratoconus. We'll still be taking questions for Dr. Rohit. Please, ma'am.
Hello, sir. What is the current status of AI in the imaging of keratoconus?
I think most of your indices have some or the other AI inbuilt in it. Um, Keratoconus being such a multifactorial disease, just putting an AI on it will never yield the results what you want. But if you add multiple, all those parameters, I felt that needs a huge big data for it. So eventually it will come, but at this point of time, it's at very, very early stage.
So while we wait, Rohit, following up on that question, do you see maybe a scenario where, irrespective of the kind of topography machine anybody uses, we can input that data into a central kind of repository to be able to compare topography maps, either color coded or based on numerical data, so that any patient going anywhere will get some information about what happened in the past and what will happen in the future?
We worked on some risk scoring, and the progression is based on risk scoring. But like I said, the sensitivity is very poor at this point. Not poor, it's very average. So, but still, it will give you a some kind of a red flag or green flag on what he should be doing. And the second thing is unwanted calling somebody for 3 monthly pentacam or topography probably will be avoided. See, I see a lot of them being asked for coming for 2 months, 3 months. See, you decide on if AI has a prediction that this chance of progression is less, then you can call the person after a year. So the footfall to hospital can be reduced.
Thank you. So we look forward to hearing from Dr. Ritika Sachdev. Ritika, all yours.
Thank you, Dr. Praveen, for this opportunity. I'd be talking about epithelial mapping and corneal biomechanics. My talk is fairly basic. It's for the clinician and how to use these two tools to understand more of the puzzle of keratoconus. These two tools add to the understanding of keratoconus beyond the tomography. Now, why do we need to go into biomechanics and epithelial mapping is simply because the keratoconus journey moves that way. We were earlier diagnosing keratoconus on the slit lamp, then we moved to diagnosing it earlier on the tomography. But the earliest change that comes in is the biomechanical change, and hence it is a good place to enter in the diagnosis of keratoconus, to catch it early, to document progression, as well as to exclude these cases from refractive surgery. Now, this is one of the most famous quotes of biomechanics, that cornea is not a piece of plastic, by Dr. Cynthia Roberts. The cornea is a heterogeneous structure with viscoelastic properties. The elastic properties more akin to solid, coming from the collagen. The viscous properties more akin to liquid, coming from the ground substance. Now, why we talk so much about biomechanics is now that we have a commercial device to really monitor the biomechanics. The device we use is the Corvis ST. Corvis basically stands for corneal visualization with Shimplug technology. So you're using the images, which is 4,000 images that can be captured in a second. And because this air puff that is used to deform the cornea lasts for 31 milliseconds, we are going to have 140 images of the cornea. So you see, with an air puff, the cornea deforms. So you are applying a force on a surface and getting a contour response, that is a change in the shape of the cornea. This shape change is an indicator of the biomechanical strength of the cornea. Just to showcase the normal and a keratoconic cornea, you see here that a keratoconic cornea is weaker biomechanically, hence the magnitude of deformation is more. The other points to note is that the central area is going to deform more, and there is a greater difference between the central and the paracentral area, right? So this simple monitoring using a lot of images can be broken down into biomechanical indicators, which is what we will be doing. Now, these are actual real-life examples from my patients. You see here that though the response is from normal to keratoconus, simply by viewing it on the video screen does not give you the real picture. Hence, we break it down into mathematical indicators. These are some of the mathematical indicators, and this is the contour response, the dynamic response of the cornea to force being applied on it. When the force is applied on the cornea, the first response is for the cornea to first aplanate, the surface becomes flat, and then the surface goes to the concavity mode, right? So these are the two phases. Obviously, it will go into a deeper concavity if it is biomechanically weaker. So these are the indices that we get. First is the deformation amplitude, which means that the displacement of the apex and the paracentral area 2 mm away from the apex will be much more. It will go down deeper if the cornea is weaker. Okay, so this is the deformation amplitude. Then we have the radius. The radius, because it is going to be more curved, the radius will be shorter, so the inverse of the radius will be larger, right? So a larger inverse of the radius will again be a weaker cornea. The third is the stiffness. Stiffness, like Dr. Rohit said, is a great indicator introduced by Dr. Cynthia Roberts' team. Whenever you have a weaker cornea, you will require less force to deform it, right? So I think this is a great example. Think of a basketball and a beach ball, right? This also helps you understand the confounding factors. So if a ball is thicker, you will need more force, right? So the stiffness will be more. And if you inflate it fully, for example, if you have a beach ball or a basketball that is fully inflated, it will deform less. So these are the two things, the thickness and the IOP, which will also be interplaying into these parameters. So now coming to the IOP, just like a beach ball which is fully inflated will deform less, similarly a cornea which is at a higher IOP will deform less with the force. So these are the indicators that you must keep in mind. So when you see the cornea map of the biomechanical indices, there is an IOP that also comes in, especially if you're looking at progression. So also try to look at the IOP and see if it is matched or it is confounding results further. Like I said, these mathematical indicators are combined to give you a screening report. So these are largely the three mathematical indicators that I told you about, combined with a thickness profile. it was seen that when the thickness profile was added and a composite index of the Corvus biomechanical index was made, the sensitivity and the specificity was higher. So this is the Vinsegura screening report, which comes on the dashboard of the Corvus ST. And you see that these indices give you a composite CBI, which is color coded. Anything close to 0 is good, anything close to 1 is bad. You also have the color coding, and 0.5 is taken as a relative cutoff. Now there are newer indices that are coming in. This was by Ahmed Elshik and group. This is the stress strain index, which has now been incorporated into the Corvus ST. This index is very important because it doesn't have as much confounding by the intraocular pressure. It basically gives you a curve. The closer, the more straight it is and closer it is to 1, it is a good value. But do note that the reference subjects here were about 50 years old. So practically you may not get a value of 1, you may get a little lesser in younger subjects, but less than 0.5 will be fishy. What is most important is that this can be used to assess the progression of keratoconus or the effect of cross-linking. So if the curve is shifting to the right, that means the cornea is getting softer. And if the curve is getting more vertical and shifting to the left, that means the cornea is getting stiffer. The great magic happens when you really combine tomography and the biomechanical indices, which is the combination of the pentacam and the Corvus ST. When both the machines speak to itself, so you have the bad D, which you already have with the pentacam, you have the CBI or the Corvus biomechanical index, which I told you about, and when you combine these two with some degree of AI, it comes to the tomographic biomechanical index, the cutoff for which is usually taken as 0.29, and this is one of the more sensitive and specific indices that has been shown. That if you see, this is a paper showing that it is the TBI, which gives you a better sensitivity and specificity for detecting the fellow eye biomechanical weakness in patients who do have keratoconus. So if these three indices are, even if TBI is suspicious, take it with more sense of concern than if the CBI is suspicious. Just moving on to some case discussions. Now this is a normal topography for most of us, and we would be happy to do a refractive surgery in this patient, right? The tomography gives you good results. There is the bad display seems to be quite normal, but if you look at the Corvus biomechanical index, it is completely in the red zone. Right? So this has pointed out to a biomechanical weakening of this cornea. Let us look at the fellow eye of this patient. This is the fellow eye. So it is a frank keratoconus in the fellow eye. So it is only the biomechanics that has possibly detected an early keratoconus with a normal tomography, and such a patient should ideally never undergo a refractive procedure. This is just to show the two tomographies. So biomechanics is perhaps a missing link that does add to our understanding of keratoconus. Another relatively good-looking refractive display map, you see that the tomography is largely normal, and what's really great is that all the indices are also in the green zone. So I think it's a clear green signal to go ahead with the refractive surgery. However, the fellow eye of this patient has keratoconus. So though we have discovered newer frontiers with biomechanics, a lot still remains undiscovered, and there are missing links which will add to our understanding. One of the missing links, of course, is that this is measuring the central 3.5 mm in most cases, and to have multimodal biomechanics and, like Dr. Rohit said, collagen imaging and other modalities come in will add to the pieces of the puzzle. So biomechanics is a great tool, but the more you know that you don't know. Now coming to the epithelial mask on the anterior surface, this is just to show a representative that the epithelium tries to regularize whatever is irregular. So in a normal surface, the epithelium will be regular. However, if you have a small stromal cone, the epithelium over the cone tends to become thinner so that the overall corneal surface looks normal. What does this show? This simply depicts that when you do a Placido-based topography, the anterior surface will be masked. The cone on the anterior surface will be masked, because this is what you see on topography. However, when you do a tomography, the posterior elevation shows up. So do you always need a topographer or a plus tomography? Or can you add the epithelial mapping to a simple topographer to know more, right? So a lot of general practitioners just have a topography, and if they use the OCT to simply look at the epithelium, they can unmask the topography which has been masked by the epithelium. I'll be showing you some examples of this. Now, most of, like Dr. Rohit pointed out, most of the OCTs now have integrated the epithelial thickness map, and simply by subtracting the epithelial thickness by the total thickness of the cornea, you get the stromal profile. So you are able to get the stromal irregularity unmasked. This is what the normal epithelium looks like. It is thicker in the inferior part because of the pressure of the lids, right? So this is what a normal epithelial map is like, and you should hold this as a reference. In keratoconus, this was actually by Dr. Dan Reinstein way back in the year 2000. They noticed that the epithelium over the cone is thinner, and there is a donut-shaped thickening around it. This is in stark contrast to the normal profile of the epithelium. So let us look at this case. This is a patient who has keratoconic cornea, and just look at the epithelium pattern. It is thin over the cone, and there is a surrounding thickening. So this is a pattern which you very commonly see in keratoconic corneas. And for the general ophthalmologist, if you do not have access to a tomography system, do combine your topography with an anterior segment OCT to get the epithelial masking out and a clearer picture of the corneal stroma. So all in all, these are again some cases. This is a patient of mine with keratoconus. You see that the epithelium is thin, and all the indicators, the biomechanical indicators, are in the red zone. This is again another patient. The epithelial map you see so beautifully throws out as big a finding. But however, do note that the epithelium pattern may not always be as consistent. But if you have a doubt in patients, you must look at the epithelium, sorry, like I showed you here, right? So they are all in all pieces of the puzzle which, when fit together, make you diagnose better and assess progression better by unmasking the epithelium and understanding the biomechanics better. So I think my final musings are keratoconus, I think, is something that is a deep interest of mine, simply because each keratoconus is a learning, not only about the disease, but about science and mathematics, about nature and life itself. Thank you for your attention.
Thanks a lot, Ritika. The more we know, the more we don't know. So, but thank you for simplifying corneal biomechanics as well as epithelial mapping. Have you also noticed in any cases where the topography is really abnormal, but the biomechanical indices appeared to be relatively normal? And what did you do with those cases?
I would, if the topography is abnormal and the biomechanical indices are normal, I would still wait to watch the topography being stable over a period of time. And obviously, I think we should take into account the age of the patient as well as the gender, because I do feel pregnancy is a great trigger for a lot of progression of keratoconus. So given the age of the patient, and also if the topography is abnormal, we must do an epithelial map, because sometimes the epithelial hyperplasia is creating an abnormal topography, which is not a stromal irregularity. So really, to put all the pieces together, topography abnormal, epithelial map normal, I would wait. Topography abnormal corresponding to an area of epithelial hyperplasia pointing to a more regular stroma, I would not worry so much. So that is really the key factor. And biomechanics, of course, adds to your understanding, but sometimes does add a little bit to the confusion.
True. Any questions for Dr. Ritika Sachdev about corneal biomechanics or epithelial thickness mapping? Rohit, Rashmi, do you have any questions or comments? Right. Thank you very much, Ritika. And again, now we welcome Dr. Rashmi Deshmukh. Dr. Rashmi Deshmukh is a cornea and refractive surgery faculty member at LVPEI. And in fact, she's the one who put this course together. So thank you very much, Rashmi. And Rashmi is going to be speaking today about newer modalities and understanding and current concepts of collagen cross-linking, which is the natural progression of what we're going to do after we identify keratoconus.
Good morning, everyone. Thank you, sir. So today I'm going to be talking about cross-linking in thin corneas and what are the current concepts. So we all know that keratoconus is a progressive ectasia and collagen cross-linking is one of the only known modalities to halt progression at the moment. Conventional protocol, as we know it as Dresden protocol, was described by Wolensak et al. In 2003, and it uses 3 milliwatts per centimeter square of UV light for 30 minutes. However, the endothelial cytotoxic dose, which is the 0.35 milliwatts per centimeter square, this dose is reached at 400 microns. And that is one of the reasons why it becomes difficult to use Dresden protocol in corneas that are thinner than 400 microns, of stromal thickness, I mean. Studies have shown that almost 25 to 30% of patients presenting with keratoconus will progress and will need collagen cross-linking. And of these, 25% corneas are thinner than 400 microns. So we are talking about almost 1/4 patients who might not be suitable for Dresden protocol or conventional collagen cross-linking. So what are the different techniques that can be used for sub 400 corneas or thin corneas? So there is a list like hypotonic riboflavin, customized epithelial debridement, contact lens assisted or lenticule assisted cross-linking, and transepithelial CXL, and newly introduced adaptive fluents. So we'll discuss each of them one by one. So first, coming to hypotonic riboflavin. So hypoosmolar riboflavin use was described by Hafizi et al. For the first time. The difference between conventionally used riboflavin and hypoosmolar riboflavin is that in conventional cross-linking, the riboflavin has 20% dextran, which makes it isotonic. So in the hypoosmolar riboflavin, they use physiological salt solution, and there is no dextran. So this makes it a hypotonic riboflavin solution and causes increase in the corneal thickness, like corneal swelling, when it is soaked with hypotonic riboflavin. So this is how hypotonic riboflavin is done. The cornea is first soaked with drops of hypoosmolar riboflavin to increase the corneal thickness intraoperatively, and then UV light is given. So there are different studies which have shown that in using hypoosmolar riboflavin, the topography changes did remain stable up to 1 year, and none of the studies yet have reported any endothelial cell loss. But the limitations are that the physiological swelling intraoperatively, there are riboflavin lakes in between the collagen which are spaced out. So the fibrils are actually spaced out and less cross-linking is expected. And of course, because I'm going to need some water, sorry. And of course, because the oxygen diffusion in hydrated stroma is likely to be compromised, the cross-linking effect is likely to be less. Although I did not come across any study that has measured the biomechanical stiffening of this as compared to the conventional one. Then coming to the techniques for the next technique for thin cornea, there's customized epithelial debridement, where the epithelium is debrided such that it is left intact over the thinnest part of the cone, and rest of the epithelium is debrided. So the thinnest part, the debrided epithelium, is going to allow for riboflavin penetration, and the intact epithelium is going to protect the endothelium. So again, there are a lot of studies which have been done on customized epithelial debridement, of which one study in 2017 has reported some amount of endothelial cell loss. So we do clearly need some more studies to know how efficacious this particular technique is and how safe it is. Then next, coming to contact lens assisted collagen cross-linking. This was introduced in 2012 by Dr. Susan Jacob and group. So placing a contact lens on top of the stroma is going to increase the thickness intraoperatively by at least 90 to 100 microns. which is the thickness of the soaked contact lens. So what they do is that the contact lens is soaked in 0.1% riboflavin for 30 minutes. At the same time, the cornea is also soaked with riboflavin. And then the soaked contact lens is placed on the epi of cornea. As long as the corneal thickness is 350 to 400 microns epi off, this technique can be used to augment the stromal thickness. The requirements are that the contact lens should not have any ultraviolet barrier. It also depends on how hydrophilic and how thick the contact lens is, because if the contact lens is more hydrophilic, it is going to soak more riboflavin. And if it is thicker, then of course the cross-linking is not going to be adequate. And again, the oxygen permeability depends on the decay value of the contact lens. So a contact lens that suits all these things should be used. There was this study by this group that was published in JRS, which showed that there was an 80% success rate of this particular contact lens, and they reported a 20% failure. Similar to contact lens assisted, there is a lenticule assisted collagen cross-linking, in which a smile lenticule is used. This was described by Dr. Maipal Sachdev and group. This will increase the effective thickness. So this is how it is done. A lenticule is placed on the cornea after epithelium is removed and then soaked with riboflavin. The advantage being that it is a biologically similar tissue to the corneal stroma, and we can customize the thickness. So the lenticule thickness you can take according to the stromal thickness that you're going to get after you debride the epithelium. The disadvantage being that literature is still sparse, and we need some more prospective trials to show what are the success and failure rates of this particular technique. And again, a comparison with the conventional technique. Then next, coming to transepithelial collagen cross-linking. So not removing the epithelium does provide better patient comfort, reduced chances of infection, and reduced chances of haze. A lot of people prefer that in pediatric keratoconus as well, but it comes with its own challenge. So riboflavin being a macromolecule, penetration inside the intact epithelium and into the stroma is compromised. So this is usually taken care of by adding benzalkonium chloride and EDTA, which act as penetration enhancers. So they loosen up the corneal epithelium, the intact corneal epithelium, and enhance the penetration of the riboflavin into the stroma, beyond which the UV light can be given. But again, this procedure has limitations of reduced oxygen diffusion through intact epithelium. The intact epithelium itself soaks some amount of riboflavin, and studies have shown that biomechanical increase in this particular technique is around 64%, as compared to almost 320% in conventional cross-linking. So it is clearly less as compared to the standard protocol. This particular study was a randomized control trial between the transepithelial and the conventional CXL, and it also showed that around 23% patients were still progressing at the end of 1 year. So the efficacy of this particular technique comes into question in certain cases. And then the last technique, which is recently introduced, is called as adaptive fluence. So this was introduced by Dr. Hafizi's group. And what they thought was, instead of thinking about augmenting stroma intraoperatively, one could think of just playing around with the fluence of the ultraviolet light that is provided during the procedure. So they studied the properties of riboflavin diffusion using the Fick's law of diffusion, and the ultraviolet energy penetration as well using the Beer-Lambert law, and came up with this algorithm where it shows what is the minimum stromal thickness required and what is the UV radiation that you would want to give. They recommended that up to 325 microns, this technique can be tried, although they have taken patients less than that, and have reported a 90% success at 1 year follow-up. However, a word of caution, because it was a retrospective series, it was not a prospective trial, and there have been no randomized trials yet to show how effective this particular technique is, and further studies with long-term follow-ups will be required. So to summarize cross-linking in thin corneas, there are multiple techniques which are available, and all techniques come with their own advantages and disadvantages. Maximum biomechanical stiffening is still reported with Dresden protocol, and rest of the techniques have less stiffening. And there are no randomized control trials where people have compared these methods head-to-head to say which one is better as compared to the other one when it comes to advanced keratoconus and thinner corneas. So one could go depending on the feasibility of doing that procedure in their own setup and taking care of patient characteristics as well before deciding on which technique to go for. Thank you.
Thank you very much, Rashmi. Very nice talk about the opportunities for cross-linking a thin cornea. Do you have any questions for Dr. Rashmi?
Your experience with adaptive fluence?
I have started trying it in some patients, but they have not yet followed up for long enough for me to say that how effective it is. But the study says that the demarcation line has been up to 70 microns from the endothelium. That is what they had attempted. So the endothelium is safe in those
How
particular.
thin do you go maximum with these corneas?
So it has been recommended to be up to 325 microns, but they have also reported up to 246 intra-op thickening, like after using. So that is what they've reported. But again, like I said, that it was a retrospective series. There are no prospective trials to determine what should be the range of the corneas that should be used in this. That way.
And which contact lens do you use for this contact lens assisted cross-linking which Susan has described?
So they've advised using the Bosch and Lomb lens, which comes without a UV filter. But again, there are studies which have compared different contact lenses by different groups, and that is the slide that I showed on decay values and the hydrophilicity comes from those
So have you
controlled
tried
trials.
this? Have you?
Contact lens assistant, I personally don't do. I've been doing hypotonic riboflavin and customized debridement more, and recently adaptive fluence is something which I started to try.
And in,
But contact lens assisted, I haven't done. If any of you.
in the panel, how thin do you go maximum with epithelium on for any of these procedures?
So up to 350 in Scheimpflug image is what our protocol has been till now. Because once you remove the epithelium, say around 50 microns, you go up to 300. Then hypotonic riboflavin causes 100 microns of swelling. So you reach up to 400, considering if it is above 350.
And do you keep doing pachymetry in between just to make sure that you're
Ultrasound pachymetry.
you keep doing it in between the
Before you start
cross-linking as
UV light also you should just see once if it has increased up to the desired thickness.
well? Yeah, thank you.
Thank you.
You had a question.
Okay.
Anything else for Dr. Rashmi? So, Rashmi, one question. When you have to pick a procedure for thin corneas and you have to debate whether you want to risk losing some endothelial cells with more effective cross-linking versus risking progression and requirement of a keratoplasty later on with potentially ineffective cross-linking, which side of the balance would you go to?
I would go towards getting more collagen cross-linking done as compared to endothelial this thing, only because as many studies that I have come across till now, significant endothelial cell loss causing a corneal decompensation has not been yet reported. And most of these patients are quite young. We don't do cross-linking in 60 plus age group where the endothelial cell count can get compromised. So that is a thought process. But again, like I said, no study has reported that there is a endothelial cell loss enough to cause a corneal decompensation in any of these procedures.
I guess the main concern is the fact that if you have a thin cornea, you will affect the endothelium. I think all other parameters being similar. I think scarring probably doesn't have to do with thin corneas. It probably has to do with the
Fluence that
inherent
we
inflammation
use.
that is present in the surrounding environment. So, can happen in either. All right. Thanks a lot, Dr. Rashmi.
Thank you, sir.
So now we'll move on to a slightly different aspect of treating keratoconus, that is aiming to treat for vision. And we have two talks. One is a pre-recorded talk by Dr. Vikas Mittal about stromal keratophakia, and I'll be speaking about a new way in which we can actually potentially avoid keratoplasties in patients with keratoconus. Keratoplasty in keratoconus, and obviously that is something that all of us would like to do. So I'll start with a case, and this is a patient which many of us would be familiar with, a patient who has good vision in one eye, very poor vision in the second eye, in the left eye, and with spectacles, the vision really does not improve. Vision improves with contact lenses to 20/40, but this is a patient who's unwilling or is intolerant to contact lens use. And the topography does show that he has quite steep corneas and also very thin corneas as well, putting him in the realm of the gray zone about what should be done next. He also has the typical features you see on the OCT, that he has quite a lot of ectasia as well as steepness and very thin epithelium just overlying the cone as well. So typically, if a patient like this presents who's not amenable to wearing contact lenses, and potentially cross-linking is not going to be of any advantage because his vision is also going to be poor after surgery, they fall into the category where you will consider doing a keratoplasty. You will probably do either a PK or a DALK for this patient, especially because there is no other viable alternative, probably maybe except Intacs to a certain extent, that will improve his vision, but even then he'll probably have to wear contact lenses. So, when you see a patient like this, you have several objectives in your mind. One is obviously you want to improve vision, you want to improve or regularize the corneal curvature, which has to do with improving vision, potentially enhancing the corneal thickness, which again is a side effect of what you'll do to improve vision, and you also would like to prevent progression. Well, all of these can potentially be achieved by transplanting the cornea, and at this point of time, there's no other procedure that potentially ticks all four of these boxes. There have been some reports about alternatives to corneal transplantation, especially from Gerrit Mellis's group, where they have tried to transplant Bowman's membrane into a stromal pocket inside the cornea. And they also have reported that there is a significant improvement in the visual acuity as well as reduction in the spherical equivalent for some patients, but it does not seem to be a very predictable procedure at this point of time. We'll learn more when we look at Vikas's pre-recorded talk. There also have been reports about using corneal decellularized lamellae into the corneal stroma from George Alio, where they found again some improvement in visual acuity as well as some improvement in the refractive error of the eye. There also have been reports from China about using femtosecond lenticules inside the stromal pockets of rabbits to see if they are biocompatible and also to see if they can change the refraction of the eye. Uh, but the problem with using grafts or tissues inside the eye is the fact that tissues do contain some antigenic properties, even though they don't have endothelial or epithelial cells. And there is a possibility of immunological stromal rejection even when you use a corneal tissue of the same species within the eye as well. So we've had some experience with stromal inlays in the past where we tried to put biosynthetic inlays into the cornea to correct hyperopia and presbyopia, and this is going back about 15 years or so. We didn't have great success because most of the inlays that we implanted inside the eye under a LASIK flap tended to become opacified, and some of these inlays also started to have stromal melts because once the opacification happened, the transmission of solute suffered, and so these patients' epithelium in front of the inlay started to melt. So eventually, we had to explant all these inlays. At this point of time, we started working with a company from Germany who was making very precise microkeratomes to shape corneal lenticules for DSEC surgery. And the approach that we took at that point of time was to try and design a microkeratome which is called a nanotome that can shave off corneal stroma from the surface, just like PRK, but without a laser. So, in effect, a sort of a low cost kind of PRK that you can shape the cornea with. We had partial success, but we also had a lot of scarring. So this project did not continue after that. But as a fallout of this project, we also started doing the same thing in eye bank eyes and transplanting this under the flap of patients who had hyperopia. And this was called LIKE. This is a procedure that is still available. And we've been able to correct hyperopia of up to +8 diopters using this procedure. And the hyperopic correction appears to be quite stable over time. But then again, you have a very limited patient profile who will be suitable for this kind of procedure. So these are long-term follow-ups of a patient who had +8 after this like procedure, and it seemed that the stromal lenticule was well integrated and did not have any reactions or rejection episodes after the surgery. So coming back to our patient, and you can see that this patient has visual acuity of 1 meter uncorrected in the left eye, very high refractive error, correcting only to 20 by 200 with spectacles at this point of time. This is when we started to explore trying to put in a porcine collagen lenticule inside the corneal stroma of the patient. So this porcine collagen lenticule actually is pre-treated, it's decellularized as well as it is cross-linked multiple times so that at the end of the process, the lenticule actually becomes quite rigid. And after this, we also looked at literature about using of porcine decellularized material in medical science, and they've been used in several areas in human medicine as well. And we also looked at evidence of lamellar keratoplasty being done using acellular porcine collagen stroma, and they seem to have relatively good success as well. So, utilizing this prior knowledge, what we did for this patient was we tried to create a stromal flap. I'll go to the actual animation, and this is just an animation rather than the actual surgery. The surgery is quite simple. All you need to do is create a stromal pocket. Initially, we used the Visumax laser, similar to a smile pocket. But later on, we started using the FS200 laser, where we could create deeper pockets inside the corneal stroma. And once you create the pocket, this implant was injected inside this stromal pocket and then unfolded so that it actually spreads itself in the pocket and covers the area where you potentially have the greatest thinning as well as the weakness. So the procedure is about a 10 to 15-minute procedure done under topical anesthesia and is also quite simple. So this is the patient we're talking about. This is pre-op topography, 1 month post-op and 8 months post-op. And you can see that the cornea looks relatively clear even at the end of the 8 months post-op visit. And the change in the curvature of the cornea is actually quite surprising. You see, this is preoperatively, you see a lot of ectasia, but post-op with the implant inside the cornea almost regains its natural curvature. And the most exciting part for me, at least, is the fact that regularization of corneal curvature from somebody who has topography K values of close to 80 diopters, if he goes back down to 45 to 48 with close to 33 diopter flattening in the center, I don't think any procedure is able to achieve that kind of flattening in patients who have severe keratoconus. And this remained stable for a long time. Whatever flattening we had at the 1 month visit seemed to be similar at the 8 month visit as well. The epithelial map thickness also seemed to increase, where he had very thin epithelium overlying the cone. The epithelium started to thicken and started to become a little more normalized over time that for this patient. Eventually, this patient with a -11 and a 3.25 preoperatively correcting to 2200 at 8 months, he had a zero spherical error with a cylindrical error of -5, and he was correcting to 2060, which was something that the patient was very satisfied with without having to wear contact lenses at this point of time. So before this procedure, we also applied for CDSCO approval for a limited clinical trial because this was a new procedure that was being done in human eyes to look at safety and efficacy. We included 5 subjects in the trial, and in all 5 subjects, we had a significant improvement in the refraction as well as the best corrected visual acuity at the end of 3 months. We have about 18 months follow-up for these patients, and we found that the mean K also had a significant amount of flattening at the end of the trial, and this was probably one of the most gratifying aspects of implanting these lenticules inside the eye. But all did not go very well, and in fact, we had a patient who appeared to be a very good candidate at baseline. Again, very thin cornea, very steep cornea, and when we implanted the xenia inside the eye, she did well for several months. But at the 3 month visit, she had an epithelial breakdown over the implant, and there was stromal lysis over the implant, and so we had to remove this to prevent any further damage. Post explantation, she did relatively well. The epithelium healed, there was no scarring, and the cornea sort of went back not to the original curvature but slightly lesser than the original curvature after surgery as well. That's the pre-implant as well as the post-implant topography. Very similar before and after, showing that it can be reversible, but we did not achieve the objective after implanting this lenticule. So the question that I get asked the most is, why not use human collagen in the eye? The problem potentially is the fact that in several countries the supply is limited, unlike in some countries like the US and in India. And unless it is decellularized with the same process, the antigenic load can still be pretty high. And so the process of decellularization is probably going to be quite intense and could lead to significant wastage of tissue as well. So once this is optimized with porcine collagen, it can be applied to human tissue as well. And the type of collagen that is used is similar in porcine as well as in human eyes. And because of the immune privilege, we have not seen any immunological or antigenic reaction. Even in a rabbit study we did before this, as well as all the human studies that we are doing right now. And with the increased number of keratoconus patients that we're continuing to see, we also are seeing that with the advent of cross-linking, there is a reduction in the number of transplants that we're doing. And hopefully, with procedures like these that can be done in a simple way with just about a 15-minute topical anesthesia procedure, we hope that this is something that can prevent the need for corneal transplants in several of these cases as well. So, in summary, the stromal lenticular implantation still needs to be perfected, but at this point of time, it seems that it does improve corneal curvature and visual acuity and is an option for patients who are not suitable for traditional collagen cross-linking and does have the potential to avoid the need for a corneal transplant. And eventually, I believe that this will form a part of the algorithm to manage keratoconus where it fits somewhere in between those who are contact lens intolerant and those who require a corneal transplant. Thank you very much.
Excellent work, Praveen. And I just wanted to ask you, in one of your cases, you showed that there was a thinning and there was some. So, if when you're series of cases, if you do a confocal microscopy on them, and what we have seen is whenever we have this nerves and dendrites and all of them being quite differential, your rate of inflammation and corneal melting, because they're all related to the MMP's activities. So whether you can actually prevent in your future cases just by doing this scans, so that you can predict. So those who have higher level of inflammation, poor nerves, can be pre-treated, say with cyclosporin or one of the newer dry therapies, and we can see that a lot of their activities come down. So
Right.
I think that might be, you can use it as one of your protocols in your clinic. Or if you don't, if you have the confocal done on that particular case, that will find a lot of answers.
Yeah, in fact, we have confocals pre and post in all patients. We have looked at them, but I don't think we've looked at it from the aspect of inflammation or even looking at the
Dendritic
nerve
cells.
and dendritic cells as well. That's a good idea. We'll probably look at it.
Because many times when we looked at a short cohort of patients, those who have heavy, lot of haze, lot of this corneal thinning, excessive flattening, all of them had issues, which biomarker issues, which you could pick it up on the confocal microscopy.
Right.
So probably going back and look at those things would probably help, because that is the main nidus of how this activity starts.
Yes, I think we had two patients who had epithelial healing issues or epithelial breakdowns. And common factors that we seem to identify between the two is both had the pockets that were slightly shallower as compared to the other patients. So that's something that we probably will change. And the other interesting aspect is both happened around the 3-month time point. So maybe it has something to do with the solute transmission, maybe inflammation as well, and both of them happen in the center. So that probably tells us that in the periphery it might be doing okay, but the center it's not doing very well. Yeah, but we'll look at the confocal. That's a good suggestion. Thank you.
One question, Dr. Praveen. How deep do you go with the pockets? Yeah.
We went in the initial patients, we did about 120, which was just like what you would do with Smile. But later we started doing 140 and 150 as well. So we think the deeper the pocket, the better is the effect. But again, these are patients who have central corneal thickness of only about 350 or less than 350. And several of these patients, if you have thick epithelium in the center, you might not have enough stoma to create a real good pocket. So I'm a little scared about going deeper than that. That's why 140, 150 has been the limit that we've gone to.
And do you cross-link these corneas after you put in these lenticules? Or?
At this point of time, since the lenticule itself is cross-linked, that is not part of the protocol. But we believe that in the future, after implanting the lenticule, cross-linking might make them less susceptible to corneal melts like you saw in this case. So maybe that's something that will come out in the future.
And unfurling these implants inside, is it an issue through the pocket or?
You mean taking them out or?
No, putting them in.
No, it's a pretty simple surgical procedure. It's nothing, no big deal. So any good anterior segment surgeon, I think, should be able to do it with hardly any training.
And the diameter, how much do you
You can
make?
customize it.
Okay.
The ones that we used was about 7.8 to 7.9 millimeters. So you can customize it to whatever diameter you want.
And the thickness of these implants, how much? How thick
The
are they?
initial series of implants that we used were about 70 microns thick.
Okay.
The next series of implants, that is 3 more patients that we did, were 30 microns thick.
Could you use the smile lenticules and decellularize them and then use them in place of these? Or
We thought about that, but there's several disadvantages. One, you don't test for viral markers in smile lenticules, and so you probably would not have that information. You also will not be able to control the refractive power of the lenticule. And also, the lenticules that are shaped that we have right now, they are shaped to have a curvature of 44 diopters. So they actually cut in that pattern. Smile lenticles are not. And that's probably the reason why we believe smile lenticles might not be as effective as these.
and
And
these
the
are
diameter is smaller as well.
and these are pre-cross-linked, is it? These?
Correct.
Oh, thank you.
Thank you very much. So to go on, we'll.
Can I ask a question?
Yes, of course.
Yeah. So, since we saw up to 1 year follow-up, the xenia lenticules, the porcine collagen lenticules, they were not getting populated with the human host keratocytes. So it also means that it is not integrated into the human cornea as such, but it is just causing topographic changes. It could have its own advantage and disadvantages, considering that it is reversible and we can still take it out because it's not a part of cornea yet. So how would you see that? Is it like a good thing that it is not a part of the cornea up to 1 year, or do you see it as like a disadvantage in any way?
I think it would be a disadvantage because it seems now that it's hyper cross-linked. It's cross-linked about 20 times the amount of normal cross-linking that you would do for a cornea to prevent progression. So
Yes.
that makes it extremely rigid, but that also probably is making sure that the collagen is so compact that it's not allowing any cellular migration into the cornea. Previous lamellar transplants using porcine corneal tissue have shown some cellular integration into those transplants, and even recombinant collagen that has been transplanted inside the cornea have shown some cellular migration inside them.
Yeah.
Those were not cross-linked. So I think this probably has to be optimized where you need to reduce the amount of cross-linking so that there is some amount of integration and some amount of transport of solutes, and it still potentially can be removed from the cornea like you will do with the smile lenticule in the future as well.
Yeah.
So I think it still has to be optimized, not perfect yet, but this is a very exciting development from the point of view of managing keratoconus. As of now, it's not for sale. It's only research. So, depending on the results, we have to submit our results and then look for approval. So, we guess that it should be about in a year, year and a half or so. Thank you. We are almost out of time.
Dr.
Rashmi,
Vikas Mittal's talk is 7 minutes.
okay.
Should I play that? Okay. I'm playing it, but it needs to show up.
Minutes are left in the session. Do you know?
Good morning.
Minutes are left in the session.
ये वीडियो है। अच्छा वीडियो है। हाँ, प्री रिकॉर्डेड टॉक भेजा है। तो
Okay, we have time.
okay.
The next talk is a pre-recorded talk by Dr. Vikas Mittal, and this is about doing stromal keratophakia using the Bowman's membrane transplantation technique that Melis had described. In the meantime, as we wait for the video to come on, if any of you has any questions or suggestions about any of the talks so far, we'll be happy to discuss that. Depends on the goal. Intacts in general tend to correct about improve visual acuity by about 2 lines on Snellen, best as well as uncorrected. So if that is something that the patient is looking for, then Intacts is a good solution. But most times patients with Intacts are looking to transform between contact lens wearers to spectacle wearers. And a majority of times it doesn't achieve that outcome. in advanced keratoconus. Moderate keratoconus, it still is a good solution.